intervention. And the data I will present now is collected by research assistants through observations during labor and birth and questionnaires. And they were collected between May and December last year. Sorry. And between May and October, data was only collected weekdays during daytime. And in October and November, it also included weekends, evenings, and nights. So when you look at this data, you will see that there's a difference in how many participants we have collected data on. And this is a common approach in quality improvements where you start very small and you test the change, and then you learn from your mistakes and successes on a smaller scale before moving forward on a larger scale. Yes, next slide, please. Can we have the next slide?
Sorry, Johanna, my machine is acting up. Let me first shut down and then I come back.
Okay. So when you're doing that, Doreen, I can just share some of the insight of this project. So as you have already shared, the Midwize-Ambassadors, the 7 midwives at the China-Uganda Friendship Hospital, has been the one leading this project. And I have been the one analyzing the data and presenting graphs and so on to lead the quality improvement project, or for them to analyze and to see what was needed to move forward with the quality improvement. And we also have on this call, I think Christina is here as well, and she has been the clinical midwife instructor. So she is very skilled in the hands-on support of providing intrapartum support and giving birth in different dynamic positions. So she has been the one training the 7 Midwize-Ambassadors on like the practical skills. How do you actually perform a birth on the birth stool, for example? And how do you protect the perineum when the woman is on the side or on all fours? Because of course that's important skills to have. And then we use the train the trainers approach. So the 7 Midwize-Ambassadors then trained and paired up with the rest of the staff. And encouraged and engaged them to spread the change throughout the department. So me and Christina have not been training the other staff, but we have been in close contact with the Midwize-Ambassadors who have then been leading the project. Doreen, should I share the screen instead?
Liz, can I share the screen, please?
Yes, please do.
Liz, my ability to share.
Great. So I think you can take the slide with the first graph. Yes, this one. Thank you so much. And Sarah is not on yet, is she? No.
She's not yet on.
Okay. She has some connectivity problems, I think. Okay, so I will continue until she comes on, and then she will hopefully take over. But this will start with one of the most important outcomes, and it's about women's decision-making while choosing birth positions. Because the quality improvement is not only about getting as many mothers as possible to give birth in different positions, it's about giving the woman the right to choose. And in this slide, we can see that in the beginning of the project, 15% of the women decided what position to give birth in, or the woman or midwife decided jointly. And as a result of the quality improvement, this increased very nicely to between 64 to 96% in July to November. And the dip you see in October is because we also expanded to night time, and it took a month or so of PDSA cycles to get on the right track during the night sessions. Next slide, please.
Hello.
Hello.
Hello, everyone. I'm so sorry about the challenge I had in the connecting with the link, but I'm glad that it has now connected. My apologies, please.
It's lovely having you here,
welcome.
Sarah. I will just hand over to you now for this slide then.
Thank you, Johanna, for standing in for me. So good evening, everyone. I'm Sarah Muwanguzi, and I'm really glad to be given this opportunity to talk to you about this Midwives initiative, quality improvement initiative led by midwives at China-Uganda Friendship Hospital, Naguru. Just to continue with the slide, this slide shows that women giving birth in a dynamic position. So at Naguru, we were able to carry out with this project, and this is a
I'm having challenges with these slides. I don't know. Sarah, proceed though. Hello?
Sarah, your microphone is mute. Can you unmute and continue the presentation? You have muted yourself.
Hello?
Hello, Sarah, are you there?
Yes, please. May you share the screen, please?
You're not seeing the screen?
No.
Oh, Lord. Can anyone see the screen?
The screen is seen.
Yes, the screen is seen.
Yes, the screen is seen.
Screen is there. You can see that graph.
Oh my God, I'm not seeing the screen. Okay, share.
You can see it now, right?
Ooh.
Maybe you try to refresh your machine.
To refresh. I'm just saying.
Hello, Sarah. I want support now. Sarah, what can you see on your
I'm
screen?
just seeing participants. I'm seeing participants.
Okay, thank you. Now you scroll your phone. You scroll it to the right. You'll be able to see the screen. You scroll the screen. Just push it on your right. You'll be able to see the screen. Have you seen it?
Oh yes, thank you.
You're welcome.
But even then, the screen is freezing.
Okay, I've seen the screen, please. So,
Okay,
yeah.
Perfect.
Now let's talk about the intrapartum support. Hello?
Yes, we can hear you.
Yes. Now this screen is showing intrapartum support. I know Johanna has explained all this. So this is among the components that we looked at. And in intrapartum support, you can clearly see that we were able to support these women during labor. And these are some of this is the kind of support that we gave. So if a woman gets gentle strokes, hello, massage, or given instructions on breathing, data would still be collected, and then we would get to know how that went about. So this slide shows that in the beginning in May, when we started giving this kind of support. It's a psychological and emotional support to the mothers during labor. In May, it was very low, 27%. This slide, actually, this data was collected using observation. They could observe and see what the midwives are actually doing. So in May, it was at 27%. And in June, 50 mothers were observed. And as you can see, there was a drop to 23%, but it kept on increasing. Women could, the data collector would clearly see that the midwife is supporting the mother, giving her the gentle strokes on her arms, massaging her, and also giving her instructions on how to breathe calmly. So you can see that that kept on increasing from July. It steadily kept on increasing like that, and up to November, as you can see. So this clearly showed that these women were getting the support and they really valued it and appreciated all that kind of care. They felt good, they felt the warmness, and in a way it affected their outcomes of labor because they could actually mention at discharge that they felt good, they felt loved, they felt the warmth, they felt the support. And this could also be done by their companions or the midwives. The companions of their choice could be their husbands, their mothers, their sisters. So what we could do, especially in a resource limited area like Naguru, where the human resource was not so much, we would teach the companions, we would teach all those relatives who are of their choice to support. We teach them what to do, and they continue doing all this. And there are also many other supports like the rebozo dancing, you know, the ambulation. So that is that with that slide. So we really saw that increase, and it was very good because it would really make them have very good birth experience. Next slide, please. So the other area we looked at was the perineal protection. And with perineal protection, we looked at minimizing episiotomies because we know it is a standard. Episiotomies are no longer routine for the prime gravidas, and also they're painful. They're painful. So we would really look at minimizing them as much as possible using the standards or the measures that we learned. You know, we have learned this in class, but we also got to know that we were not doing much in minimizing episiotomies. It's really a nasty outcome for experience for the mothers. So we embarked on giving information to our fellow midwives and also encouraging the mothers. So this was one of the measures that we really looked at. So this slide shows that we looked at in the beginning, before the intervention, the episiotomies were quite many. As you can see, in May, at the start of the initiative, they looked at 35 women, and out of those, 41% of them had episiotomies. But then in June, out of 50 mothers, these episiotomies kept on dropping and dropping, as you can see, from 41% to 23% in June. And then in the observed 38 mothers, it had dropped down to 8%. In August, there was a slight rise, but then it continued dropping, as you see that slide, up to November. In a total of 143 women, only 10% had episiotomies. So all this was the drop was attributed to the the care that we continue to give to these women to protect their perineum. For example, how did this happen? Just knowing that episiotomy is not routine was also something very important for the midwives to know, and also trying to minimize them as much as possible. Only give an episiotomy really when it's needed. So that really got into their minds, and they really did all possible ways, give the woman time, no rushing to give episiotomy. There's no rush, because we know that the second stage has a very good duration of a whole hour, and all they needed to do is to watch and continue to only give it when it's needed. Then, still in perineal protection, this slide shows we also embarked on all that we could do to maintain intact perineums. So the total number of women, the data was collected to quite a number of women, and this was still observational, but also use the registers to show, to tally with the intact perineums, because in our register, we do capture the women who have had the intact perineum, but we purposed to really have a woman go away with an intact perineum, because it's a very good birth experience, minimal pain and all that. So you see that in May, there were very few women, 28% of the women had intact perineums, but we also saw the graphs raising, the percentage was raising, the percentage of women getting intact perineums kept on increasing because of all those interventions that we kept on doing. For example, the slow delivery of the baby's head. There's no rush. The woman delivers in between contractions. We encourage this calm breathing and also only pushing when it's necessary during a contraction, and not over pushing, especially depending on what position she's in, because if she's on a stool, no need for all that strong pushing. If she's in the lateral, she also pushes. So all those interventions were really very much encouraged. We encouraged the women and continue to support them to adopt the positions they have chosen, but also have the knowledge of the dynamics of maintaining the slow delivery of the head, and also things like the warm compress. We also tried it out and it worked very well. We got a kettle and would boil water and then just have a warm gauze pad, and then you just apply it over the perineal muscle. In a way, the muscle just relaxes gently. It's not rigid, it just relaxes and then allows the expansion, or the expansion, and allowing this head to come out gently without hurrying and without over pushing. So that really attributed to these results of the increased perineums. And the women really felt good, because they're not going to labor with nursing wounds, all those things of getting sepsis, and you know how our conditions are generally. So they really feel happy not to have a wound in their perineum. So that was also something good that we saw at Naguru, that it really worked well. So we learned that when we do not hurry this woman with that understanding, the rationale of really maintaining an intact perineum, the scientific reason is very, very important, because with the warm compress, it is the way it relaxes the muscle and prevents its rigid. Sometimes when it's contracted and it's compressed, there are high chances of it tearing. So the relaxed muscle stretches easily and minimizes the tears. Then with the
Sarah, let's be a little bit fast in the interest of time.
Okay, I thought you were controlling my time.
Yeah.
Thank you. So this next slide is about the overall satisfaction with the care during labor and birth. So at the point of discharge, during the discharge process, after educating these women and giving them information for going home, but before they go home, we also did like, we did like a client exit survey, yes, evaluation of the care at discharge. So we asked them questions, how they felt about the labor, and what positions did they choose? Did they choose it themselves? And like quite a number of questions. And also ask them how satisfied they were. So this slide shows us the level of satisfaction. Most of them strong, the satisfaction kept on increasing. So in May, when this was asked, you can see in a number of 35 women, the level of satisfaction, those who strongly agreed was at 30%, but it kept on increasing every month. And like you can see, September, there was a rise. And then in October, it kept on increasing. So the level of satisfaction by the clients about the care during labor kept on increasing. And this, when we asked them why, they felt good about the intrapartum support. They were happy about allowing their companions in, and also teaching their companions what to do. For instance, most times companions just sit and wait to see what the nurse is doing. But this time they're involved, they're participating, and they're also informed on what we want them to do. They feel so happy. They get the warmth of their own getting involved in the care of their delivery. So the intrapartum support was well appreciated, and also allowing them to choose the position they want, because they always thought it's the nurses to choose for you. Moreover, that routine dorsal position, which is very uncomfortable, but here they're able to choose. So we saw that satisfaction increasing every month, and we kept on because we valued what they value. Yes, so that is really that on that slide. I'm sorry, I'm rushing. Maybe next slide, please. There was a slight drop on this one, but like you can see from 70 to 60, but you know, those other factors that sometimes come in, especially with issues of human resource. Sometimes we have so many students who have not understood what is going on. And on that note, we always encourage the midwives to make sure they orient all staffs, new staffs who come, new students on a daily basis. And sometimes if the students are so many and the midwives are few, they get overwhelmed. So that accounts for those slight drops in the satisfaction, especially for those staff on the unit who are not well versed with what is going on routinely. So it calls for more time to engage with the students, engage with everybody new, to make them know what is continuously and mandatorily done on the unit. So we get to identify all these periodically on a weekly basis. When we do our PDSSI course, we identify all those reasons, the gaps that have brought about the fall, the drop in the performance, and then we continuously engage, brainstorm, come up with analyze the problem, and then plan to implement whatever we've agreed on, and then we continue to see the rise. So the PDSSI course are continuous. Actually, we did them every week. We have to find out, identify the gaps, and then plan for and do whatever we've agreed on, and then later study. And then we continue to see these graphs on a weekly basis, so that we keep checking ourselves and also get to know what we need to do more to see that we maintain these levels of satisfaction for our clients. Next slide, please. Next slide, please. Hello. Hello. Next slide, please.
I think Benjamin's computer is freezing.
Oh, sorry.
Yeah, she has moved. He has moved.
It has moved. So with this slide, you know, we also realize that in doing all this, in helping out with the intrapartum support during labor and allowing women to choose their positions, and also helping to have their perineums protected, yeah, we also realized that in a way it impacted on the national indicators, because somehow we realized, if you look at this in May, the postpartum hemorrhage, because we also capture this indicator on a monthly basis, we somehow realized that the PPH, postpartum hemorrhage, had also dropped. The number of PPH women getting it had also dropped from 7% to as low as 2%, which is something that we need to also explore more and try to understand where the correlation, how the correlation happened. But you know, of course, if a woman really is well supported, usually it also translates into minimal complications. So we also realized this. Next slide, please. Actually, in July, we didn't have any PPH. So we also noted that there was a drop in the babies whose Apgar scores were less than 7 at 5 minutes. So in May, at the start of this initiative, out of 35 women, 22% of the babies, sorry, out of 35 babies, 22% of those babies had Apgar score, low Apgar scores, below 7 at 5 minutes. But we also kept on seeing this drop. In June, it dropped to 10%, it dropped to 3% in July, and in August, we actually 55 women, no baby had any Apgar score less than 7. And as you can see this, and this went as far as November, where out of 141 mothers, all babies had very good Apgar score, no baby less than 5%. So this is also a national indicator. And in a way, this kind of intrapartum support and midwifery kind led initiative, in a way, led to a drop of the babies. You know, we did not look at only the mothers, but also realized that our babies also, in a way, had good outcomes. So we just need to study more and understand also where this correlation is. But like I told you, that with all that support, this is also another, this is kind of the advantages, because we recognize that there were many more complications in these women that we supported with this kind of care. So there was a lot to learn here, and it really was so motivating. So this next slide is to talk about companion present at birth. And we know that this is a national standard. It is the standard for a woman to have a companion of her choice. So as we went on with this initiative, we also encouraged this. We saw that companions were very important. There was an increase in the number of women who recognized that support of their companions while in labor. Naguru is such a space-limited hospital, you would really wonder. But we embraced it and tried it out, and it worked. Because one, we had very few staff. We have human resource issues, shortage of staff. Sometimes you're alone on duty, sometimes 1 or 2 at all shifts. So we brought the companions on board, the ones of their choices. This could be their husbands, mothers, sisters, friends. So we gave them the chance to choose their companions. And this was also well appreciated. In April, you can see companion percentage of the women who enjoyed their companions was very low. but it kept on increasing, gradually increasing. And you can see in September and October, it went as high as 55%, 61, up to, there was that slight drop in November, but it was just minimal. So we learned that these women value to have their own companions of their choice. And these companions, very interestingly, they always there, but we also recognize that they were very redundant. They escort the mother, but just to be told to wait outside. Escort the mother, but also just to be told, just be there, and very redundant. But here, we saw that this was a very good resource. We taught them, we gave them information on how to give the intrapartum support, how to give those gentle strokes, how to do the hip squeeze, how to encourage the mother to breathe calmly, how to dance with her, maintaining the uprightness and maintaining the mobility in a way helps labor, shortens the labor, because the descent will happen. And companions also don't want their mothers to stay long in labor, so they embraced it. And we actually saw shortened labor, and also good, very outcomes. Women felt good. So presence of companion was on the increase. And with the midwives, we continue to encourage this. And because of the space, we said at least one companion. And even if they're within the same corridor, because our labor ward is not so big, but in the same corridor, as a group, together with their lessons and all that, they're doing the rebozo. We have a video, a screen where we run the videos, and they all just enjoy it. They continue dancing, they continue stroking, understanding that they will not need augmentation, the artificial augmentation. We also tell them, as you do that, you're opening the oxytocin tap. As they do the strokes, they're opening the tap. So it minimizes augmentation. It is using pitocin and all that. So the labor continues with good natural oxytocin. It becomes very interesting and exciting. So thank you. Is there any next slide, please? Yes, Roxanne.
Who has, by raise of hands, who has a question, so that we can have Sister Sarah attend to that right now. If you have a question, kindly please unmute and put across your query.
Yes, Alice. Alice has a question.
Yes, please, Alice, proceed.
Thank you very much, Sarah and the team, for the wonderful presentation. I wanted to find out, Sarah, that's a very good innovation, having the partners or any person really who could help the mother, to comfort the mother. I'm wondering now, like in our labor ward, really, were you doing it in a private room or it was in the main labor ward? I'm not trying to picture and look at the China, hospital labor ward. So I don't know whether I didn't pick it. I don't know where exactly. Was the mother in a private room or in the general labor ward? Thank you.
Okay.
Okay, I'll just ask here, Peter Oyster here. Thank you for great presentation and good initiative. I wanted to know, especially about the experiences of the nurses themselves. What was their experience? And two, how were all these things possible, having to be able to do those things, to be able to warm water and have warm tissue to apply? And finally, is it now the practice in the hospital, or it was just a study? After the study, what is happening? Thank you.
You're welcome.
Any other questions so that we can have the questions and she responds at once? Anyone with a question, please unmute and put it across.
Okay, good evening, presenters, and thank you very much for the presentation. Mine is a question in relation to some of the positions that the mother takes and the ability to have infection prevention and control, especially those that involve, for example, having somebody being on the falls and etc. Thank you, and over to you.
Thank you for that. I think now, Sarah, you can first attend to those as people come up with more questions. If you have a question, you can also post it in the.
Hello? Hello? Hello?
We can hear you, Sarah. Proceed,
Okay,
please.
Yes, please. Thank you so much for all these questions. In regard to Alice's questions, I'll begin with Alice. Naguru Hospital her question was to know whether it was in a private room or the main labor room. At Naguru Hospital, we do have the main labor room, but we also have some private rooms. And this could occur in either of these. In the main labor room, we have actually 2 standard delivery beds, but the other beds are just the ordinary beds. Yes, so we have 4, okay, I could say wider beds, but they are partitioned. There's privacy, at least some audio privacy. And then in the private rooms, we also have the curtains and all that. So it depends on what the mother opts for. And so our state of our labor is that for those few labor delivery beds, we can only use them for 2nd stage. It compromises this standard of keeping the mother on the same bed for all the stages. But however, with the little space we have in the corridor, we are able to have these women in that corridor together. They put their mats and it's enclosed. So our first stage is like a group first stage. And then we can only send them to the delivery beds to deliver, and of which they can still use any position of their choice. They can still have a stool within that curtain. They can also use the lateral. They can do all 4s and all that. Sometimes in extremes, some little bit of privacy is compromised, especially when maybe a woman is on a stool and another is on a bed. In those cases when the deliveries are so many. But that is how we go about with it in regard to privacy. But we do try to observe it as much as we can. But this intrapartum support, they have their lessons, their bodies are not exposed, but their couples can be within the same area on their mats, and they continue to dance, do all those other things that we talked about in the intrapartum support. So that is, we are limited with space, but I wish we had a very big labor ward. It would really, the privacy would really be at a higher and better way. If a woman opts, like for the private rooms, that can still happen. A couple can just get in their room and they continue with the support in whatever they want. And the midwife can always go there anytime to monitor and also continue to support them and give information. Then in regard to Dr. Peter's question, he asked the experiences of the midwives and nurses. We actually have more of midwives in the labor ward. And so maybe in that context, the nurses, maybe I'll just talk about it as the midwives. It's still representing. I don't know whether he meant the nurses, but in that umbrella, as nurses and midwives, we usually call that. So their experiences, they have both good and Sometimes they also ask questions, but we continue to support them. They feel good about informing these women and seeing them talk good about them. For example, most of these women who have been informed at evaluation, at discharge, they actually know the midwife's name. They also know whatever the midwife has engaged with her. They will speak it out. They'll say, midwife so and so was so good. She allowed me to turn on one side. She allowed me, she allowed me, she allowed me. She gave me information and I was able to choose what I want. So they really valued that. And the midwives were also very motivated by hearing this good report from the mothers talking about them. So in a way, they continue doing it because psychologically they feel they're appreciated. So, and then their other experiences was to do with having more knowledge on how to actually support the woman in those various positions, because you all know that we are used to the dorsal position, and the mechanism of action and the management of labor is the same, but you have to really understand how to maneuver it, especially if the woman is in a knee chest, or if he's on squatting, or if he's in lateral. Because remember, we always know it's the occiput to come out, drops out of the symphysis pubis, and then the maintaining flexion and all that. So those little bits were a bit of challenge to them. But when we understood, we had to come in to practice more with them, especially the niches. They could say, that one is a bit difficult for me. And because I thought this is what should happen. But now remember, if the woman is in niches, it means the occiput is below and the face is above. So they just needed to understand those little nitty-gritties. And when we kept on explaining to them, they said, okay, so you mean this is it, and then more practice. And this, so that's why you saw that they could just go more for the lateral positions, but needed to understand more the mechanism and how to engage, especially if it's in the niches. Like, for example, with the squatting, there was also that experience with the stool. Now, with the stool, remember, this is now gravity. The babies, the bones are wide, and the gravity is also bringing down this baby. And if the woman continues to push hard, they had that experience that, first of all, when they put the women on the stool, they get tears. So we had to come in and ask why. That was their fear. But the fear was they were applying the skills they used with the dorsal position on the stool to be a little bit different. Because here, instead of over pushing, you actually have to tell her not to push, to only push when needed. So you find that those kind of differences, they needed to be very clear with them. And for example, on the stool, you're struggling to tell her not to push, to part, because the head is just coming. There's no need of extra energies here, which is not unlike with the dorsal position, where almost 4 people have to hold the mother. One holds the hand, the other, the thighs and all that to flex the legs. She can't breathe. You have to hold the head. You need like 5 people to support the woman in dorsal position, which is not the same with the stool. So we had to bring this clearly in our weekly meetings and continue to mentor them. But we encourage them to share as much as possible. Others would say, there were those experts who knew the stool, so they could always refer to them. You should, sister so-and-so is good at the school. And in a way, they could just push those deliveries to that particular sister. But now we come in to tell them, you have to share, you have to mentor all of this, so that these women should benefit from these positions they have chosen. So there are quite a number of experiences, cutting across in all these components. For example, when it comes to the intrapartum support, they continue to, you remember we used to tickle the breasts bring the contractions, you do it roughly, and also touch the abdomen. And please, you even get an assistant to touch the abdomen so that the contraction comes, and also touch the breast. But this time, they also say, they appreciate and said, you mean this time it really has to be gentle. If you have to open the oxytocin tap well, it has to be gentle. So they keep on reflecting and learning and appreciating and getting very, very excited to hear the feedback from the women. And how warm and how do you use the tissue? This was a very good innovation after the training and after learning from, Johanna. This was her PhD work, plus her team from Sweden, but it was also Amanya, her data collector. She also, the research assistant, they came in and taught us more how to do all these things. So we had to.
Sarah, Sister Sarah, let's keep it brief. Time,
Okay,
there is a lot. Let's
Yes.
address the issue of infection control briefly.
Yes. Okay,
Yes.
please. Thank you. So with IPC, with some positions, for example, the stool. With the stool, the principles still apply. They're still the same. For example, if you were to use a polythene sheet to protect the bed, this is exactly what you do with a stool. She has to put on her polythene sheet, which drops into a small basin. And then the floor definitely may not be littered because everything will just drop down into the basin. That is in regard with the body fluids and the delivery. So the stools have to be decontaminated the same way. There has to be hand washing. Everything is actually remains the same with IPC. All the standards have to be observed. So maybe I could just comment on the stool, which looks like unique. And then with the labor support, intrapartum support, the mats, the cleanliness, everything, the midwives have to really be keen to give information and support them to maintain, to prevent infections as much as possible.
Okay, thank you very much. There is a lot of queries about scale up in the chat. Yes, scale up. We are still looking at that, scaling up into policy and all that. It's not stopping here. There is another project that was implemented by the Midwize capacity building team in Mukono Hospital. So that is ongoing. Thank you very much, Sarah, for the presentation. And in the interest of time, I'd like to inform all people registering for CPD points that the link is in the chat group. Please proceed. And this presentation will be shared on the YouTube channel of the forum. And thank you very much for attending. So again, in the interest of time, I beg that we stop here and we invite our chairman of Busoga Health Forum to give us closing remarks.